So as indicated in our agenda, the next panel is our carrier panel. And we're switching gears a little bit because we've got Representative Tom Sherman, who's a physician and plays a role in the House Health and Human Services and Elderly Affairs Committee. The insurance department ends up in front of Commerce a lot, but in my work, I've ended up actually in front of Tom's committee pretty frequently. One of the nice things about this event is we've heard some recommendations, we've heard a lot of background, we've heard from the providers, but to the extent the insurance department has a direct role, we regulate the insurance companies. So they're the last ones up here, and we've got the opportunity to have Tom ask them a number of questions about what they think works and respond to the recommendations that are presented before us. We're very lucky to have the folks that are here today. When we did our hearing in the fall, we made a specific request to get the medical directors from the health insurance companies. Today, we have really the people who are leading the policy for their organizations as much as anybody is for any of these organizations. So it's, I'm really looking forward to hearing what they have to say, and I'm going to turn it over to Tom to moderate this panel. And again, like the other pieces of the event, you will have the chance to ask questions.
Thank you, Tyler. I did want to, it's hard for a doctor to get behind a podium and not spout forth a little bit. So I did want to just say three things. In listening to the panelists and the speakers this morning, the first one, it was an experience when I was running for office, and I was speaking with a constituent from the other party, and he was saying, so what do you think is good about the Affordable Care Act? And rather than going into a whole detailed analysis of the parts of it that I thought were important, I said, well, what has it done for the country? And he said, I don't know what you mean. And I said, this is the first time in my entire medical career, which spans over 20 years, that we have embarked on a reasonable, reasoned, in-depth dialogue on what the future of healthcare is going to be in the country. So if there's one benefit that I think all parties can agree to, it's that we have started down a path which I think is irreversible of coming up with a different paradigm for our healthcare delivery system in the country. The second observation is that the size of New Hampshire, one of the things I absolutely love about New Hampshire is that the size of New Hampshire is an absolutely perfect size for an incubator project. The ability, not only do we have many different socioeconomic classes, but we also have an academic medical center, we've got a lot of interest at UNH, and we have some really top performing provider groups, and now we have a number of carriers. So it's a place where we can actually do some experimentation and really come up with, hopefully, the model for the rest of the country. And then the last part is that we can't do this in a vacuum, and the vacuum that is not here today as much, although I do see some of my fellow legislators, is the public from the patient perspective. If we move forward at lightning speed, as has been suggested, and we don't bring the public and the legislature along with us, we will find that they are, number one, going to feel left out of the process, and number two, that they are going to be afraid. And they are going to embrace their personal experiences that they have had with their primary care physician and feel that threatened. And they are going to, and I speak from experience within the legislature, cite that the reason we should not move forward is because we're disrupting the traditional doctor-patient relationship. And so I think keeping the perspective of how do we fully inform the public and how do we bring the legislature with us and make all of them experts in this process, which is what we need to do to move forward, is probably the biggest challenge to have a successful outcome. So I'm done spouting. I did want to, I went through all of the speakers' bios, and I like to be disruptive. So I'm going to start by picking on Lisa Guertin, who is President Anthem Blue Cross Blue Shield in New Hampshire. And I just was reading through her bio, and I just like to point out something that was said earlier, that we are all patients and we are all human. So I'm going to point out one part of her bio that says...
You're human, Lisa.
Everybody gets roasted here, so it's fine. And it's not really roast. It strikes me that people wear many different hats. They come in as, title is President, Anthem, Blue Cross Blue Shield in New Hampshire, but perhaps an equally big part of her life is that she has served on the board of the Industry Association of New Hampshire, Southern New Hampshire University, New Hampshire Citizen Health Initiative, and New Hampshire High Risk Pool. That's a person. That's not a CEO or a president. That's a person, and that's what we all have to remember about this. Beth Roberts, Senior Vice President, Regional Markets at Harvard Pilgrim Health Care. She works, she's on several boards, but New Hampshire Health Plan, City Year New Hampshire, Riverwoods Group, and Riverwoods does incredible work. The 2010 Heritage United Way campaign, and she has won several awards for this out of her occupation work, which is just spectacular. Glenn Gerhard, Vice President, Medical Economics at Cigna Health Care. I hope you know the difference between 2 and 3, which was pointed out as a difficult mathematical equation, at least for some of us. As Vice President of Medical Economics in 2013, and is responsible for Cigna's medical cost trend and affordability initiatives. That's great background, but Glenn initiated Cigna's sponsorship of the Hartford National Alliance on Mental Illness, which is the NAMI walk. That makes him human. Kevin Lewis, Chief Executive Officer, Maine Community Health Options, and great to have you here. But your human side, I'm just kidding, but the improving healthcare access for underserved populations and representing Maine's community health centers, that's yeoman's work. And these are the kind of things that, give us perspective when we go into jobs that involve numbers and jobs where there's profit and all those other things. Hopefully this is the perspective that we take to that job. And finally, Tom Policelli, CEO of Minuteman Health. He led the strategic initiative to create the first private sector exchange business, and he has worked, we have a West Coast bias here a little bit. He's worked with the group health of Puget Sound in Washington and Kaiser in Oregon, and working with underlying populations. So it's just, this is a human group, and I want them to bring that perspective along with their occupations and their professional background to the discussion today. To start out, what I asked them to do, and this is a really brief presentation, 2 minutes each, to tell us in their experience what has worked either in New Hampshire or in other states, addressing the topic of the day, which is evolving payment systems, what works and what doesn't. Just a very brief 2-sentence example of what has worked. And we'll start with Tom Policelli of Minuteman.
Well, thank you. Are we sitting or are we standing?
You can,
all right.
Whatever you're most comfortable with.
All right. Well, since it's 2 minutes, we'll just run through.
You don't need the mic.
Yep. Okay. Great. Well, thank you also for saying we're human. My 16-year-old, it's unclear if she'll be driving tonight, and so she may be not totally sure that Dad's a great guy at the moment. Thank you. So we also divided, in addition to 2 minutes, we were each given a subtopic, and I confess I got the easiest one. I got transparency. So transparency, good. Okay, so but so let me try to make it a little harder, because everything we're talking, the danger in a lot of what we're talking about here today is it's easy to say, to start nodding up and down, right? Choice is good, transparency is good, a fee for service, not so good, right? That's pretty easy. So when you start saying something's good, you have to say until when, or exactly what's going to make it work better. And so what we've seen in transparency so far in industries far and wide is that there's early adopters. They grab the information, they run with it. And they're the ones that the initial savvy shoppers, and they drive the rest of the market. So you get a quick pop of 5-7% of the people in any industry. And then you go up to about 15%, and that's your core. And then comes barbecues, where the person at the barbecue says, I saved $200, and everyone starts listening, and then you start seeing this swing up. That's great, that's what we're all here for, and works wonderfully. But it really doesn't matter if there's transparency, if there's not the ability to fire somebody. You have to be able to have the choice and be able to take action as a result of that. And so, again, looking at other industries, because healthcare it's too early to see, but in other industries there's basically 3 big reactions that competitors or suppliers tend to have when there's a disruption coming along and transparency is coming. And I think it's going to be fascinating to see how this market changes. So first thing that generally happens is the incumbent players try to differentiate their own pricing to crush the new, right? So you have a hospital has an MRI center, they're charging $2,000. A guy opens up an MRI across the street for $500. The hospital drops his to $400, drives the new guy out of business, and cost shifts onto some other service that doesn't have competition. Happens in industries galore, so we got to protect against that. Second thing that generally happens in any industry is the incumbent starts to consolidate, right? And that's the danger in some of the ACO stuff we're talking about here, is that we've got an over-consolidation, and then you can't segment out the prices. Again, you can't have the consumer fire somebody and hire somebody else. And so the last stage, and this is the hopeful one, this is the one we need to get to, the last stage is when the incumbent providers need to restructure their cost structure and need to restructure how they provide services in order to compete and be sustained in the marketplace. So my own little plug here in the transparency is that's not enough. We've got to make sure that we have choice and the ability to fire people. The sound of it. No wonder my daughter's not happy, but so
Thank you.
go ahead.
Next we'll go, Glenn,
Yes.
with Cigna.
So I get asked to kind of expand upon that with benchmarks. And so before I go into benchmarks, what I want to really start talking about is really our alternative payment models, particularly ACOs in particular for Cigna, and our use of benchmarks in our ACOs and how that helps to drive improvement in the system. So first off, with benchmarks, a key component of our ACOs is really assessing where a provider is today versus a local market is typically how we start off. So we want to benchmark them against where they are, and then that really opens up the discussion of let's look at a real fact set. Let's see what's working, what's not working, and then that can set our goals and targets going forward for the future. And for us, so at this point, we've got 120 ACOs across the country. We believe in them. We believe in the data and the benchmarking part of it to really be able to drive the success. And our very first ACO was right here in New Hampshire. And so we've been able to kind of begin here. It was a great state to begin with, some great partnerships and being able to build from there. So learning from that success, really what I see is kind of the key is the data. Getting a fact set on the table to begin a discussion. And so that's really the key. So we certainly support benchmarking from a perspective of being able to begin a conversation and begin the dialogue. I think some of the things that where we've run into issues as far as things not working is where some providers or even ourselves want to really get too creative with the data, how we want to create quality benchmarking, and let's create something new and something non-standard. And I think what we've found over time is that being able to get a fact set that everyone can agree to and something that's common, something that's industry standard, something that we can build from is really key to making it go forward. And then a second thing I would say is really reacting too much to year one data. So we see ACOs really as a journey, that it's a partnership, you're changing behavior over time. And so as you're starting it, it's an agreement that year one is not going to be make or win or lose, and that's it, we cut bait and run from there. So we really had to do even a lot of internal politicking in our own area, in our own company, to really just make sure that everyone's committed to the journey, that it's a change in behavior and continuing to have the regular discussions, continuing to partner. We've seen the results on a multi-year basis that make it worthwhile. But changing provider behavior, changing consumer behavior, changing our own internal behavior is a journey. And so just that we're very supportive and going forward.
Okay, thank you. I think right now it's just a 2-minute on what we're doing in terms of payment reform.
I think you could sort of blend the two.
Okay, all right. So as Representative Sherman mentioned, and Kevin Lewis, Community Health Options, and in terms of payment reform, I'd like to talk about what we've done with version 1.0, 1.1, which is really our value-based insurance design, which involves not only support for patient-centered medical homes, which we can talk about and how we've approached that, but I think more fundamentally our chronic illness support program and what we've done in the area of benefits supporting people with in need of behavioral health services. So specifically the chronic illness support program, we waive the co-payments for people needing access for a variety of chronic conditions for the routine management of those conditions. So we waive co-payments for generic drugs, and we reduce the co-payments for preferred brand drugs. There are no co-pays for labs, durable medical equipment, and office visits, whether a PCP or specialist. And that has resulted in reducing the financial barriers, eliminating financial barriers for people to get the right care at the right time in the right place. And this falls really in line with our mission, which is to partner and locally with members, with healthcare professionals, and with businesses to provide meaningful benefits and affordable benefits for people to then afford better outcomes and wellness. So the result of it is it's a little too early to tell in terms of any kind of return on investment. Right now we're booking this as a cost, but we can see in terms of pharmacy the incredible power it's had. We expect, well, in 2014 we had over $1 million of waived copays just for the drugs on the drug side of chronic illness support program, and we're trending right now at over $2 million for 2015. So that's a little bit about our approach and how our mission, we live our mission in terms of our operations, policies, and day-to-day actions. I got the meatiest part of the paper, which is an impressive paper, and I have quite a few notes to run through, but I want to be mindful of time. I thought it was a very impressive paper. Representative Sherman, do you want me to go through these points now, or?
Sure, it would be.
Or are we going to loop back to the paper itself in terms of the recommendations?
Why don't we go round and then come back, and you can be first, because I think the other gentlemen have talked about their presentation.
All right, sounds great. Now you're going to present up here?
Yep. Okay, I have a visual aid. Kind of geeky. Sorry about that. I think the picture will help, so I did bring a picture. We can get that cranked up. And so we were given 2 minutes to talk about success in this space. And I think the success, and not just ours at Anthem, but I would say the success among all of the parties represented here over the past 2 years has been pretty incredible. And I think one of the challenges is that the report looked at the market between 2010 and 2013. And I think on the provider side, the payer side, we've come a long way since then. So in general, at Anthem today, as I stand here, we have 18 of the state's 26 hospitals in some kind of risk arrangement with us. And we have 63% of the state's primary care physicians in the program that I want to highlight today as a success. So the program is called Enhanced Personal Health Care, and it really was based on the successes and learnings that we had with medical home and ACO pilots right here in the state, working with some of our friends right across the room, as well as around the country. And I actually do think that is a great model for us to study as we think about how to work together going forward, because we came together to learn, and then we kind of went back to our day jobs and applied those learnings. And this is how we applied those learnings. So the premise that we were acting on is that primary care, which accounts for a very small percentage, if this funnel is meant to be the total healthcare spend, and it all starts with primary care, which is only 6% of the total spend. And then everything flows from there, whether you're in a gatekeeper program or not. All the hospital care, outpatient care, everything else that you're going to get is out there in the bigger part of the funnel. And the idea is that primary care, although small, has a huge influence on all that other healthcare spending and quality and outcomes. So we launched this program in 2013, and again, today, 63% of the state's PCPs are in it, and that number grows to 82% on 7/1/15. And at its core, it's definitely about payment innovation, because it creates a new little PMPM payment that you see over there on the beginning of the funnel that allows a practice to interact with their patients in different ways. It allows them to transform what they do, and for the first time pays them for something other than what happens in those little 15-minute increments when they're sitting across from a provider. But beyond that, they are also, they have the opportunity for a gain share if savings occur and quality targets are met, and I want to underscore that. But more than that, it's really about collaboration, which I agree with Dr. Rosenblum when she stressed the importance of that, and really working together to transform care delivery. So over here you see what PCPs get and what they give. What they get is actionable data and reports and insight, as well as practice support from us so they can begin to succeed in a value-based environment, whether they're a small 1 or 2 person practice or the largest sophisticated system. What they give in turn is improved access. We expect that they will have better access for their patients, greatly enhanced care coordination for patients, and in the words of our medical director, Dick LaFleur, he feels the most powerful thing is that for the first time under this program, they're actually being rewarded for working with the people who need their help the most. And that is, again, getting paid for the kind of conversations that Kevin Callahan spoke about that they really weren't able to have before they were trying to do off the side of their desks. So if that's a picture of how the program works, and you told me how this goes. Okay, let's talk about how the savings occur. We will be releasing the actual dollar figures in just a couple of weeks. The results have been really strong in the program. Let me give you some headlines. On the cost side, they did beat their medical cost targets by a significant amount. 22% of those savings flow back to the PCPs as their gain share, and the remaining 78% go directly to our ASO customers as avoided claims, or it benefits fully insured customers because lower claims are used to set their premiums for the next year. So I think that's important. And remember, that funnel that we're talking about, the spend for those PCPs participating is about $631 million a year. So it's really, really significant money that we're talking about affecting. How they achieve those savings will look really familiar to anyone who knows about the medical home pilots here. Reduced ER utilization, use of more cost-effective sites. For the first time, doctors are asking the same questions as their patients about where should I go for that service? Where can I get the best cost and quality outcome? Better discharge planning. And in the bottom, you see some of the quality measures that they have to meet in order to get a gain share. We were really excited that on every one of those, their quality was better than their control group. So that's adult preventive measures, PD preventive measures, diabetes measures, really all of the measures, quality measures that we looked at. So I feel like this is a really good example of what's possible in this space when we work together on concepts, and then we all kind of go back, bring it back, and apply it in our worlds, as you heard some of the hospitals talking about exactly what they're doing as well. So,
thank you.
Thank you.
Does Beth Ann have visuals?
I do not, and
Okay,
you can
so
call
you
me
guys can all
Beth.
come back.
Beth Ann feels a little formal. So I will stick to just doing the innovation right now and
Yeah.
then talk about the
We'll come back.
comments
Yeah.
on the paper after.
Thank you.
So Harvard Pilgrim is the company that I represent up here today, and we have an innovation that we're very excited about that we just launched in December of 2013. And the beginning of this is really a product that we brought to market, which is called Elevate Health, which is through a joint partnership with Elliott Health Systems and Dartmouth Hitchcock Clinic. So why is this different? It feels to people, or some people say, it's just a limited network, what's the big deal? It is absolutely not just a limited network. The foundation of this product is built on population health. So you heard Kevin and you heard Dr. Rosenblum talk about the importance of keeping the patient in the middle and focusing on population health. That is the very crux of what Elevate Health is. It's starting to blur that line between the insurance company and the delivery system through looking at total premium and therefore total medical expense. How do you work collectively to lower both of those? And blurring those lines in what do we do versus what do they do. So in some cases, the insurance company and the delivery system are doing the very same things. Well, what is one of the easy costs you can get out of the system is eliminate some of that duplication so that you're really doing it collectively, keeping in mind no longer how to push patients into different environments to get care at a lower cost, but instead, that doesn't matter anymore. What really matters is what is the total cost of health care and how do we continue to sustainably lower it over time. It's not just through getting rate concessions from the various people in this network, but it's about working together in order to give the patient the right service at the right time in the right setting. Sounds like a very old concept because back in managed care days when it first came out, that's all what we talked about. But this is picking partners to work with so that we can do that in a more systematic, holistic way and get back to the patient in the center and creating that environment where we think about that together at the same table. So that's Elevate Health, and that's our innovation that we think is a very sustainable way of moving forward.
And that's a New Hampshire product, correct?
It is a New Hampshire product, and it started out in December of 2013, and we're up to around 18,000 people in that product today. So it's had good growth.
Thank you. I'm going to turn back to Kevin unless Tom, you or Glenn want to add to your original thoughts on transparency or benchmarks. Okay, so Kevin.
Okay, great. So I was asked to talk about the Payment Reform Strategy 2 in the paper, which is really all about the alternative payment methodology. And to begin with, in terms of what I laid out earlier by way of our mission, so the framework that I come to this is really in that partnership model that we've heard about earlier in the earlier panel, that we really want to partner with providers to make sure there's a successful end result. So it's partnering on the quality measures, it's partnering on the baseline establishment, risk adjustment, risk corridors, risk exclusions, et cetera, et cetera. There are a number of things that, and I want to first congratulate the authors and the New Hampshire Insurance Department for the work on this, because I think it does, as Representative Sherman mentioned earlier, we're here because of that work, and having this discussion can only help as we try to continue to sync up resources so that we're not duplicating, we're not contradicting, and that we're optimizing the tremendous amount of resources that we pour into the healthcare economy. So overall, the report places the right emphasis and weight on payment reform and on alternative payment methodology. The strategy calls out some key turning points and essential elements, and I'll mention those quickly. One is certainly identification of provider risk, that has to be first and foremost as we consider different arrangements, and ensuring that there's significant and substantial panel size that's sufficient to handle that risk. Second is the necessary care of constructing a workable and comprehensive agreement. We can't go into this without putting in place the necessary curbs and the necessary safety net, if you will, to ensure success. Inclusion of education is an essential component, and it's brought out in this strategy number 2. And you'll see I emphasize that education when I come back to sort of final conclusions here. But it's so important across the field that we have everybody working from the same knowledge base. We can't have imbalances. Earlier there's talking about an imbalance of power. We can't have imbalance of power because of misinformation or lack of information. We really need that education across the board. Emphasis on care coordination. It's really the area, I believe, of great promise, perhaps greatest promise. showing real results as Beth was mentioning, getting to the right care, right place, right time. This is a particular passion of ours at Community Health Options in terms of working closely with providers so that we have the right handoffs and that there are no gaps in care. Inclusion of a commission comprised of a broad set of stakeholders, including patients, including members, the insureds. The Big Ten approach can engender probably the best decision making. There is a downside, which I'll mention in just a moment. And then lastly, a focus on methods and approaches for providers to consider their readiness for risk sharing. So that full-on review of where any given provider or system is with regard to their readiness is essential. So, however, there are significant drawbacks, I think, in what's been presented, and these may be drawbacks that I've inferred. Apologies to the authors if I interpreted it incorrectly. But I would point to the model contract approach. While there's some value to that model contract in terms of education, it really could, and it could jumpstart some developments. Having a model contract be the determinant of quality measures themselves, or whether providers pass a financial durability test, for example, could undermine the richness of locally specific and organically rooted partnerships between the insurer and provider. So it gets back to our focus on being local and being responsive to the needs of that locality. We're actively engaged in care coordination, as mentioned, but to centrally mandate and regulate care coordination, as indicated in the paper, that was my interpretation, could actually backfire and jeopardize smooth and effective handoffs, as well as nimble and timely sharing of clinical information. Those are the essential pieces, that it has to be nimble and timely for purposes of treatment and improving health outcomes. Third, forcing the alternative payment methodology through the narrow straits of a model contract risks the sacrifice of the very innovation and locally nuanced approaches that reflect the strengths of each partner and how these alternative payment methodologies can help us achieve the triple aim, which has to be built on an enduring foundation. Fourth, the downside of the commission is the amount of time that it will take to move through the process and the impact of that commission process on the present day or near-term efforts. So if that commission is to go forward, we would want to make sure that it's not going to upend or stall current negotiations or efforts that are so rich right now. Currently in 2015, there's a lot more momentum than there was certainly in 2013 or 2011 or years before. The heavy stick of provider rate regulation could have significant downside unintended consequences, including the impact on smaller provider practices, which might be forced to participate in a vertically aligned ACO whose governance is tilted away from the smaller PCP. And then the guidelines for measuring the fiscal health of risk-bearing provider organizations, they make sense, but the algorithm leaves out crucial factors essential to arriving at a mutually trusted structure that supports improved health outcome at lower total cost of care in a way that is sustainable for provider and carrier alike. And these factors, they're not all inclusive, but include agreed upon attribution, the full review of population health management capacity of the provider of the system, as well as the agreement on the service exclusions which would be covered by the carrier outside of the alternative payment methodology. A good example is transplants for a system that may not be able to accommodate that. So this really speaks to the need to separate insurance risk from performance risk, and I think everyone's on board with that, but I think probably some more attention to that could be had in the paper itself. And lastly, the paper appropriately points out the tension of mergers, affiliations, and consolidations, but then sidesteps the real possibility that consolidation, while possibly helpful in avoiding the tough governance issues of ACO development and quickly arrive at critical mass, which is essential, nevertheless removes competition from the marketplace. So we need to pay, I think, more attention to the downside of those consolidations. The paper didn't get into that. So that being said, there's a tremendous amount of movement underway and a significant appetite for alternative payment methodologies. As the strategy makes clear, careful design of ACOs and new methodologies and risk sharing is critical. So we need to separate the performance risk from the insurance risk, establish an informed and mutually acceptable baseline, as well as risk adjustment, and continually refine attribution in relation to the baseline.
I think I don't have a piece of paper. Kevin,
Okay,
but
so I was just concluding to say that, crucial, I think the most important thing to all of this, the currency of success is going to be the availability of data. And in particular, visibility of clinical information on a real-time basis. So we have great claims information, but claims information is so outdated by the time we can do anything with it. It really doesn't inform gaps in care the way that clinical information can. So we look to, if there's going to be any policy making, I think the first place to look is in the production of real-time clinical data that can be paired with claims data to inform that coordination of care and the partnership necessary between the carrier and the provider and the patient as that triangle of trust. Thank you.
thank you. I know you had a huge topic to
Yes.
take on. Lisa.
Okay, so my topic to take on in terms of commenting on the report's recommendations was in the area of antitrust and oversight of antitrust concerns. And I would say that we agree that there are both potential pros and cons of consolidation, merger, collaboration, whatever word we want to attach to it, even cooperation. And therefore, this issue does need thoughtful attention. The idea of true collaboration, especially when it involves rationalizing who does what within the system, could be a very good thing. But I think we know that the potential negative impact on cost when supply-side consolidation occurs within a delivery system is well documented, throughout the United States. So it's tricky. As you all, I'm sure, know, the idea of state action immunity specifically, through which the state accepts a certain amount of anti-competitive behavior as a given or even a good thing, and also creates its own oversight mechanism, was pretty thoroughly discussed and defeated in Senate Bill 308 last session. I think one reason that it was defeated at that time is that those debating it concluded that we needed a state plan to provide context for whatever action we were going to take. And I think, Joel, you said earlier, you need a clearly articulated purpose before you set off on any one of these very specific recommendations. We very much agree with that. I think another important question for us all to ask and be honest about is whether the state, which certainly has its own challenges with funding and strapped resources, really has the capacity to do the thorough job that would be necessary to replace the FTC in a space as important as this. I think during the debate about the bill, the AG's office actually cautioned, put up some caution flags around that. In the meantime, we definitely think that we can find ways to move forward on collaboration. Peter talked about what they're doing in the North Country to begin to work together even before this all gets revisited, and that's good. We are doing things like allowing smaller entities to put their panels together so they can get a big enough panel to participate in our gain share programs. So bottom line, we support the creation of that plan that's underway. Once it's established and the desired end state is made clear to all of us, we think the question needs to again be fully vetted so we can make the best choice, and that's defined by realizing all the positive opportunities and avoiding the unintended consequences and pitfalls that can come if you don't get it right in this space.
Thank you. And Beth Ann.
So I was asked to comment on two sections. One is setting up a commission for payment reform. And my thoughts on that one first is that I think we actually have done a tremendous job with the Citizens Health Initiative, and I know Jean is in the room, but that initiative was kicked off years ago, and the initial focus of that group, and I actually think the group that wrote the paper actually helped assist in some of the early work for the Citizens Health Initiative. Is that right? Some of the payment reform initiatives that we discussed at that table were similar to a model contract, trying to adopt what would work in the state of New Hampshire in the way of partnering with providers in a more uniform way. We adopted what I would say is some low-hanging fruit in that space, but then it was really hard to get to that consensus and collaboration around the table with all the stakeholders there. So I would say I think we have a commission. The Citizens Health Initiative is still up and running. I would suggest if we wanted to bring other discussions around cost and quality to a table, that table makes a lot of sense. They've put a lot of work into who should be around that table and how to convene on certain subject matter. So I think we have a model in place that we could certainly leverage to have those discussions. I would say before we take more drastic steps on actual payment reform, model contracts, and things of that nature, we need to let things play out. We have, like I mentioned earlier in my question, we have ACOs that developed in the last couple of years. We have integrated delivery system and insurance companies that are cropping up and taking more this joint look at premium and cost and how best to lower that in a sustainable way. We have all kinds of innovations like what Peter talked about with the North Country. I think we need to let that settle and see what happens to our cost. The cost here in New Hampshire is extraordinarily high. I'm not denying that. I think it's important for all of us to rally around that. But it's hard when you have all these initiatives that are fairly new to see the fruits and the benefits of those and immediately jump into something further. So my personal opinion is let's slow down to go faster, meaning let's slow down and see what's already taken effect and how we've bent that trend. I would suggest that if we wanted the commission to start something out of the gate, work on the benchmarks. I think Kevin hit on that. The benchmarks in a total medical expense way, not incremental little benchmarks, but a benchmark that looks at what is the total cost of care, maybe community by community, look at certain quality metrics. I have found even in Harvard Pilgrim, if we release information to physicians about how they compare to each other, and I ask physicians to respond to this, that is motivation enough. They do not like being the most costly. They don't like being the least expensive. They don't like being an outlier on quality. Releasing information goes a long way. I would suggest a commission can start there, and it would have tremendous success. The second topic I get to comment on is certificate of need. And I say it that way because I sat on that board for 6 years, and it was tremendous fun. I'm being a little sarcastic if you can't tell. I actually have to say I learned a lot. It was actually a great board to sit on, but the amount of responsibility associated with that board is absolutely tremendous if you do your work the way that it's intended to be. I would say I find the process very cumbersome, inefficient, and it's not really looking at the right things. So I think that I'm not going to weigh in on should we have one, should we not. I think there's a purpose there. But I think it has to get back to if we get state-based benchmarks and, you know, what are the right performance metrics. CON should be tied to that. So rather than hospitals having to show floor plans and what department is next to another department and all these things that nobody on that board really, perhaps nobody has a real right to comment on, get to the heart of the matter. What is it costing the consumer? Is it going to improve quality? And what is the total cost of care for that? Is it just going to be a balloon and something else is just going to pop up? What is the total cost of the community for that request for CON? So I'll stop at that.
Thank you. Thanks to all the panelists. I think we'll open it up. How much time do I have, Tyler? A couple of minutes?
10 minutes.
Okay. So let's open it up to questions from the audience. Do we have any questions? Representative Snow.
I hope I'm not going to divert us from original conversation. I come to the meeting after spending many years working in the community mental health system and representing a population that is a rather large, a substantial portion of New Hampshire citizens, really. And they have very unique needs that require very specialized services, but they also have all the same healthcare needs that all the rest of us have. And in looking forward, as this system looks at how do they evolve and how do they make their system more efficient, we hear two different things. On the one hand, we hear about carve-outs, that is carving out behavioral health services from all other health services and dealing with it quite separately. Maybe including other healthcare services and maybe not, but typically just behavioral health. Then on the other hand, we see a substantial amount of pressure integrate behavioral health services with primary care services and making that a single entity, which seemed to almost be in a contradiction. And I'm just wondering if any of these people had any thoughts, recommendations, concerns about these two seemingly opposing movements.
Sure, it's a great question, Representative Snow. We don't see them as opposing because we've rushed towards the integration of behavioral health with medical care. In fact, we made a decision last year to bring all of those claims through one engine. So we pay all of our medical and behavioral health care claims through the same process. We've hired on our own utilization management team that has both medical as well as behavioral health expertise. So we are very attentive to ensuring that we have a full view of all of our members, regardless of whether they have depression or serious persistent mental illness or whatever the case may be. The other part in terms of integration, we're proud to pay same-day behavioral health and primary care even at the same facility. So we've really looked at how can we encourage those handoffs between providers so that we don't miss the opportunity when someone's driven 2-3 hours to get into care or taken the day off from work, that we can get them into that care at the right time.
I would just add to that I think we believe that this approach that we're talking about today, and especially as it relates to fortifying primary care, letting it be what it's really intended to be, and enabling them to get there, is a tremendous opportunity for behavioral health and for integration. And there's a lot of attention to how could we help that, how could we accelerate it, what could it look like. So I think it's been a big question, and you're right, it's been done many different ways. I do believe this gives us a new opportunity to think about how you can really bring it into that frontline care in a way that will help those patients significantly.
Other questions? I have a question on our committee in the legislature. We're looking very carefully at transparency. We're closely with Tyler on this, and one of the pushbacks to full transparency is the relationship between providers and carriers, and the issues of contract privacy and I guess some antitrust, which is where this came back to the recommendations. Is there a way to have full transparency without violating your, trying to remember the correct word, the contractual side, the proprietary information? Would you like to pick that up?
Absolutely. So this is kind of my passion on this, and absolutely you can. So years ago I was at United Health Group, and I ran the consumer-driven health business there right before the HSA became law, and that really kicked the whole thing off. We're off to the races, and I love consumerism and all this, and so the CEO said, we're going to put you in charge of the website, because that faces consumers. So I said, great. I drew up the battle plan, and it was, we're going to start posting all our prices on the website for everything. And shortly thereafter, I was no longer in charge of the website at United Health Group. And this is, this is a dozen years ago, an earlier era, but that's the mentality that the industry has had towards the contracts. That's the crown jewels. That's what I got. That's what differentiates me from everybody else. So I don't want to release it. It's a secret. So when I left United, I started another company, and it was building networks, and in every single one of our provider contracts, none of them were in New Hampshire. This is all Texas, Colorado, Florida, other states. But every single one of those contracts had full transparency in it. So we could disclose absolutely anything to absolutely any consumer. And it became a big sticking point. Some negotiations went on for months because the hospital system didn't want it in or something. But we stuck to our guns. That was core, and we got it. Now, the fair thing is that if you give someone a hospital bill before they go in the hospital, it still doesn't mean anything. Right? It's 9 pages that you can't understand. So, it's our job to then take that information and make it useful and intelligible to consumers so they can make choices. But there is nothing that restricts us from doing what would benefit consumers today.
I think we need to get there as well. What I would suggest is I think the way around it is similar to what we already built, which is a member or a patient needs to understand what the full experience is going to cost. So right now our contracts really make proprietary that we pay this entity this amount of money for this service. But we know that there's technical and professional components. We know that there's ways to bundle a service that say when somebody goes for this service, it typically costs X. That is a way to overcome the proprietary nature of the contracts. If it's not discreetly saying this one charge or this one unit of service cost this in the contract, or this is what we pay. And frankly, I think that information is more relevant because patients don't even understand that there's going to be a professional bill and a technical bill. They don't understand when they're going for a surgery. They're not thinking, oh, does the anesthesiologist charge differently or separately? People don't understand that. So I would be nervous if you did it on unit of service. People would be misguided because they wouldn't be bundling those things together. They would just look at the surgical cost and not the cost of the anesthesia or any lab or any radiology that might be part of it. So I think that might be a way to overcome the proprietary nature in the contracts.
Right. Glenn, I had a question also, if I can jump in. Are there any questions from the audience? Good, never mind, I'll be quiet then.
Okay, you guys
Representative Chairman Kirk.
Thanks, Tom. I haven't heard anything about price competition here. I'm a consumer of health care, and I'd like to get the cheapest MRI because I'm stingy. So I can't do that now because I don't have the information to make the decision, and as good as Tyler's website is, it never has the particular procedure that I need on it. The discussion today has been from a central planning point of view, Russia in the 50s. I'm looking for something, yes, that's what it sounds like to people like me. We got a bunch of providers here, they're all trying to figure out how to make the system work for them, and I've been left out of it, I the consumer. So my question is, what role is there for price competition so that consumers can buy medical care in the same way they buy television sets?
I think that's what we're talking
Who wants
about.
to take that?
Well, I think part of the reason you're hearing such a concentration of what we're talking about today is really we were convened around payment innovation, and we could have another, I think, equally robust session talking about the consumer and transparency. So I think it is getting a little less attention maybe than it gets in our day jobs, just because we're focusing our talk here today. I think we are making strides there, and I think we could each tell you about the tools that we've tried. As consumers have had more reason to care because of their out-of-pocket expense, and as we see that there still are wide cost variations within the system, we would agree with you wholeheartedly that getting people to care, to understand, and to take action around those things is critical. Information is a piece of it. I think the information really started getting used when the incentives came along, and you can say it shouldn't be that way, but I think it is. And that incentive might be your benefit design itself. It might be a program that, it might be a stick, it might be a carrot that rewards you if you'll find out what your choices are and if you make a cost-effective choice. So I think you're right that if we focused exclusively on what we're talking about today and didn't focus equally on the consumer and continuing that, we would fall short of our goal. Again, we could do a commercial maybe on what some of our proprietary programs look like in that space, but it is a huge, I would tell you that strategically, the two pillars that our company's talking about are provider collaboration, including payment innovation, paying for value, and consumer centricity, and putting the person in the center of everything we do. And that's a pretty balanced scale.
I haven't seen any price ads from that.
Well, do you mean prices for our price or for the price of the end service?
Well, we used to have prices for LASIK surgery.
Yeah.
Drove down the cost of LASIK surgery very substantially. But I don't see any MRI competition. Most recent ad that I saw was for River's Edge, Elliott River's Edge, where they were bundling a service if you didn't have insurance, and it was $19.99 for some product.
Yeah.
Right.
Tom, did you
I was
want
going
to
to
jump
say,
in?
so if we look at the two layers, there's many, but two big layers. One is the purchase of the insurance product, and then the acquisition of services, if you need the services as a patient later on. So in terms of buying an insurance product, I think that is getting more transparent. Both private sector and public sector exchanges are making that more apples and apples comparisons, and there are price ads. We put out price ads at Minuteman Health saying that we were cheaper than some of the other people. Maybe so.
I like your word "some." Cheaper than some other people.
Okay, all. You made me say it. So, and I think you're going to continue to see that going on as people, as each of us with different products and different network configurations are targeting different needs that different consumers may have. So you're going to see a lot more, and I think that's going to grow. And frankly, to me, one of the most important things for the state with respect to transparency is going to be what is mentioned in the report and highlighted is the employee choice piece. So right now we've got the few people in New Hampshire who are buying on exchanges, public and private. It's very few. They can see all this. But if you're working for a small employer, and that's the bulk of the population, then you generally you pick a carrier. You get a column, right? The column is my column or his column or one of our columns here. But you can't go shopping saying what's right for me. The employee choice that is supposed to come on the public sector exchanges, in some private exchanges, allows the employee to really shop and say, this is what's right for me. I can save good money for me, and off we go. That is going to be a real game changer in this marketplace, I believe. Then, in terms of the services, it's a lot of what you're hearing here. Some services you are starting to see advertisements for, flu shots and MRIs, and you're seeing more and more of that. But as Lisa was saying, and others, it's the bundling is the hard part here. Telling someone, and even the MRI example, what kind of MRI? With contrast? Is it mid-torso? Is it where, so it's hard to just say an MRI because there's so many different little flavors of MRI. And I think we're all struggling to get there, but that's the goal.
Peter, did you start? Can I keep going with questions? Did you have a question still?
I did.
Okay. Thank you, Renette.
Did you respond?
I'm going to ask the question from a provider perspective, but I want to tell you I am human too.
Good.
You are?
I'm just wondering where we're going with collaboration between the payers and the providers. And in the context of a country that's moving, I believe, more quickly toward value-based payment, having as many brains at the table, and that includes consumers too, probably is in everybody's best interest. So the question is, beyond in collaboration, things like availability of data, or some incentives that would be for quality care or good access. Is there any movement towards shared decision making within the payer realm in working with providers?
That's a good question.
Good question. Who wants to take that? Go ahead.
Sure.
I could just, as far as our ACO model, we look at that as for larger groups. So for an integrated system, for a large physician group, we're going to be able to engage from an ACO perspective. And really we're tracking together on a risk-adjusted PM basis what do costs look like, what do the quality metrics look like, and really partnering together with I really see shared decision-making in that process as far as what are the goals we're going after. You're responsible for the care of the members. We then also have to bring in other collaboration models because in ACO there's not concentration of enough members in enough different areas to always have an ACO. So what we're working on is specialty care collaboration, so orthopedic episode arrangements, OBGYN arrangements, oncology arrangements. And so going down, looking more at the episodes and what are the cost and quality indicators and how can we partner on clinical pathways within those arrangements. And then going down to the smaller group, how do we engage and how do we incentivize, particularly on some of the chronic conditions, and being able to, if you have a diabetic and you're working to manage him, then we want to be able to compensate you for getting to the right outcome.
And as I mentioned, in terms of collaboration, we're all in terms of how we want to approach, how we want to work with providers, so that it works for both sides of the table. We don't look at it as a negotiation so much as a conversation to arrive at something that we can both trust in terms of establishing a good baseline, but also the tools to get to the end result that benefits both the provider as well as our members, because of course any net savings that we have flows back to the member's benefit. So we do look, shared decision making in terms of what we're offering by way of a portal and the knowledge library for our members. That's front and center, and we would certainly work with any ACO contract to make sure that it's synced up with your goals.
And if I could just add one very slight comment, but in our elevated health model, Peter, we also, it was really hard for Harvard Pilgrim to make this decision, but we decided to delegate care management back to the delivery system because it's closer to the patient. And by having that care management done back close to the patient, taking the best from the Harvard Pilgrim programs and the best from the Dartmouth and Elliott programs, putting it back closer to the patient, it's trying to get that patient back in the middle so that they can have very close conversations together on how best to navigate that care. Right. So that's another thing we've done.
I totally agree with Beth, and that's exactly what we're doing. We're founded by hospitals and large physician groups. That's our first couple $1 million came from them, and that is exactly where the model's going. In insurance geek terms, you don't want to put the risk without sending the responsibility along with it, right? So if you're going to be taking some of the financial and all the things we're talking about payment reform, you have to have the ability to make the decisions and manage that. And the other little insurance element here is insurance companies are not very good at doing that. Mm-hmm. That's not what we do. Mm-hmm. So it shouldn't be. And frankly, the physician is even more important than, no offense to the hospital either, but who's really in a position? It's the consumer and the physician. They're the ones who are going to be able to drive the change and get a better outcome and save themselves money and all that.
I think our time is up in our panel. I'd like to thank all the panelists for being a part of it.
So now I open up to anybody who has comments.
Is there any way to make whether individual or group, is there any way to make the individual or group health insurance less complex so that the individual consumer can understand what he's doing? I mean, I'm a broker, and I can barely understand some of the stuff in especially the small business plans. But if you go to Obamacare, and I look at an individual or the shop, it's a lot more simpler than what I see in the other markets, the non-Obamacare markets.
Yeah, I think in two areas there's a lot of opportunity. Some people will certainly make the case that the ACA was intended to simplify certain things. We do have a standard set of insurance market rules across the country, at least as they apply to the individual and small group markets. To the extent we're talking about payment reform, I think that was part of the idea behind some of the benchmarks and even the model contract that was as a part of those suggestions. If you start to standardize things, you lose some of the flexibility and creativity that might come come from the carriers and providers. But the advantage is that you've got something that's easier to understand for a broader audience. And then that goes back to this underlying complexity in which we have the reimbursement systems. So that's.
But a lot of the complexity is driven by competition, and in other words, you State Farm used to make a lot of their money by making it so complex that they could slice and dice all the stuff, and nobody knew what was going on. So you're seeing the same thing happen in health insurance.
I agree. There is evidence to suggest that the complexity has benefited certain participants in the system. Other comments?
I've got to give a shout out to the department for leading this work and for your persistence in bringing great resources to us and great analysis. And I want to personally thank you to all of you.
You're welcome. Thank you.
I just have one observation, and I think I'm just reinforcing what's already been said, but there seemed to be a suggestion that payment reform was independent or separate from the consumer experience, and I don't think it is. I think that in designing the payment reform, the consumer experience needs to be considered because there are two decision points on the part of the consumer, and that point was made by one of the panelists that, first of all, who do I go with for insurance, which means I have to understand what my costs are going to be, which means I have to understand something about pricing, and then when it comes time to using a service, I have to decide where am I going to get that service, just like any other product. And I've been in that situation, so I know how hard it is.
No disagreement from us.